Okay, so this is first part of our cardiac series. This is going to be a talk on congenital heart with some strategy for multiple choice, specifically on how congenital heart questions are often asked. So slightly different than some of the other talks that we've done here. When I say what is it, this is going to be more of a pure and many style of question. Then we're going to have questions that are differentials with bad distractors. Usually differential questions aren't well suited for multiple choice, but you can ask them. You just have to give obviously wrong distractors. And then the last thing is association questions, which are seen throughout all the different kinds of modalities. So we're starting out with ant-many type of pictures, and these are the same types of images that you probably learned as a medical student for like step 2 CK, the just basically straight ant-many pediatric heart questions, of which there are maybe six or so. So here's our first one, and you'll notice that the heart and mediastinum sort of look like an egg on a string. In other words, the mediastinal pedicle is narrow and the heart is a little bit enlarged and has like an oblong sort of appearance, like an egg. And this is transposition of the greater arteries, and the way I remember that is I think of the O as an egg. Transposition. It's actually the most common cause of cyanosis during the first 24 hours. Now, it's not the most common cyanotic heart disease, just the most common cause of cyanosis during the first 24 hours. So that particular wording is important. It's seen in infants that have diabetic mothers, like a lot of things. Basically, the aorta arises from the right ventricle and the pulmonary trunk from the left ventricle, so it's switched. And I'm going to talk about this in more depth later on in the lecture. These first cases are just for basically pure image recognition and diagnosis. Here's the next one. Same sort of deal, and you notice that the mediastinum has an appearance like a snowman. So this is total anomalous pulmonary venous return, and this is the supracardiac form of that, and I will talk about the different subtypes later on in the lecture. And here's how I remember this. We have the abominable snowman, and then we have the anomalous snowman. So to remember that the snowman is, sort of, you can say those things that sort of sound similar. There we go. And the S is for supracardiac, so that's how I keep that straight. So basically what this is in a normal situation, your pulmonary veins are going to dump into the left atrium, right? That's when your oxygenated blood is going to be returning back, and you're going to pump it out into the systemic circulation. When you have this, all of, the T is for total. If there was a P there, it would be for partial. The T is for total, so all of the pulmonary veins are going to be returning back to the right side of the heart. And because you've got all the veins returning to the right side of the heart, you don't have any oxygenated blood being pumped out to the systemic circulation, which is a big problem. So in all these cases, you've got to have some way to get the blood back from the right side of the heart to the left side of the heart. So that requires a large patent foramen ovale or an ASD, something like this, so that you can get blood going back to that side of the heart and out to the systemic circulation. So, like I said, the T is for total, all of the pulmonary venous system returns to the right side of the heart. You can see why this would cause cyanosis, right? Large patent foramen ovale or an ASD is required, and that makes sense. There are 3 different types, and we'll talk about those later. If I was going to remember one of them, it would be the supracardiac one, the one that looks like a snowman. All right, next case. So we've got a heart, sort of maybe looks like a boot. This is pretty classic Aunt Minnie for tetralogy of Fallot. Also, I want to point out that the apex is uplifted. This is a buzzword also, and I will mention that that is not present at birth. That is an acquired thing that you see slightly later, and it has to do with hypertrophy of the right ventricle. So this is the most common cyanotic heart disease. Overall, most common. So testable point, there are 4 classic findings that are described, and there's a mnemonic that I use. Prove to me that you remember these 4 things. Pulmonic stenosis, RV hypertrophy, overriding aorta, and VSD. So how bad off the patients are have to do with the degree of outlet obstruction on the right side. If it's mild, sometimes that they present in early childhood. If there is also an ASD, sometimes refer to this as a pentology instead of a tetralogy, and I will put this whole thing together for you later on so it makes sense. Next case, sort of zoomed up on the mediastinum, and what I'm trying to show is this contour deformity that sort of looks like the number 3. So this is a coarctation of the aorta, which is basically just a narrowing of the aortic lumen. Comes in 2 flavors that are testable. The infantile type, which is preductal, and they present differently, pulmonary edema, and it's more serious. And the adult subtype, that's postductal, and they tend to, this is the one you think about with the blood pressure differences. All right, next case. Sort of this, some people will call this a wall-to-wall heart or a box-shaped heart. You probably know that this is the Epstein's anomaly. So this is a normal situation here, where you've got a right atrium and a right ventricle. Tricuspid valve is normal. Now in Epstein's, the tricuspid valve is sort of inwardly displaced, and because of that you get atrialization of the right ventricle, which leads to dilation of this right atrium, and then you end up with a giganto heart. So you've got this hypoplastic, inferiorly displaced, downwardly displaced tricuspid valve. Basically makes the right side of the heart one big right atrium. You get bad tricuspid regurg and a massively dilated heart, box-shaped heart. Another thing that can cause a really big heart is severe pulmonary stenosis in the setting of an intact ventricular septum. In other words, there's no VSD. Anything that's making the right heart large, then you basically get a double-sized heart. Because the LV is normally the big one and the right ventricle is normally the small one. If you can make the RV big too, then you end up with a giant heart. The step 1 question was the mom that uses lithium, the psych drug that they give for bipolar disorder. Most cases are actually sporadic, but I would expect on multiple choice that most cases will be lithium. Okay. Now, probably saw the finding there, which is this thing here, sort of vessel. Notice it's not the pulmonary artery. It's like something separate, right? Also notice that this lung looks a little hypoplastic relative to that one, right? So there's 2 findings here. They say that vessel looks like a scimitar sword, which is a Turkish sword, the curved one. It's something sort of like this, where you've got this large abnormal pulmonary vein. It's draining into the IVC or in the systemic circulation, and you've got a hypoplastic lung. So this is actually a partial anomalous pulmonary venous return. Partial with a P, not total with a T, and it is a very classic appearance. So I will talk about PA PVR a little bit more later on in the lecture. So now let's talk about differentials with bad distractions. This is my algorithm for solving multiple choice questions with congenital heart. It looks complicated. It's not. It's the simplest one that I think you'll find. I'm biased because I developed it, but I haven't seen anyone else come up with something that's easier to use. So I'll show you how to use it. Let's walk through. So the very first thing is, are you dealing with cyanosis or non-cyanosis? And it's very helpful when they tell you that in the question, and they have to because it's like a clinical thing. What's this person's SATs? Or they just straight up say this person's cyanotic. So that's this. So you have to memorize this differential, but it's easy. If they're cyanotic, that's one of these T's. And basically it means that you've got a situation where blood has a hard time getting oxygenated and then getting out into the systemic circulation. So anything that starts with a T is typically cyanotic. Things that are not cyanotic that are common are ASDs, VSDs, PDAs, partial, not total, partial anomalous pulmonary venous return, and coarctations, especially the adult one that remember this thing presents later in life with blood pressure differences, so not cyanosis. So this is an example of how you can use this. So we've got a patient. They could show you anything as far as the chest x-ray. They could show you a picture of a shoe or a cat or a dog or something. It doesn't even matter what the picture is there. They put the picture there because they want to pretend it's an image-rich test, but you don't need a picture to solve this question. Which one's cyanotic? So you can basically eliminate things that are not cyanotic and just boom, that's the answer. And even if and we'll have questions later on where multiple options will be cyanotic, it's helpful because you can, if you don't know, you can like eliminate. You're like, well, I'm not so sure about this one, but I know that this and this are not true because these are not cyanotic. And then you're guessing at 50% instead of guessing at 25%. So I did Google that, and there are a few case reports, but nothing that for sure has cyanosis. So, let's see here. A lot of epilepsy, though. A lot of them with epilepsy, but it's responds well to exorcism, or as the Catholic Church calls it, elective surgery. So the next thing to do is to tell what side the arch is on. So how do you tell? This is sort of the difference in what side the bump is on. And when you're doing these chest X-ray cases, it's important to look for that. And if they want you to see it, they're going to pick one that's obvious. So the two classic right arch ones are tetralogy, flow, and truncus, and then other stuff. So just remember TOF and truncus for right arch. So what is a right arch? The terminology right arch or left arch is describing the relationship of the arch with that trachea. So is it on the left side or is it on the right side of the trachea? That's what that means. And there are a whole bunch of different types of right arches, but there's only two that are worth knowing. The right arch with the aberrant left, or the so-called mirror image branching. The number one take-home thing to remember is that right arches with mirror image branching are highly associated with congenital heart disease, especially cyanotic heart disease. How do you tell the difference between an aberrant left and mirror image? This actually confused me back when I was a resident, telling the difference between these two, because higher up, like if I showed you this picture, they look similar there. The way to tell the difference is you have to see where does the left subclavian originate from. If it originates from the back of the arch, then you are dealing with a aberrant left. If it originates from the front of the arch, then that's mirror image. So let's follow this one back. Following it back, following it back. There. It comes off the front of the arch. So the front of the arch is the mirror image. As opposed to this guy, following back, following back, following back, following back, back of the arch. So the back of the arch is the aberrant left. So that's how you tell the difference. So the right arch with the aberrant left is more common, most people will say. There's like one paper that says it's not, but consensus is that it's more common. And then right arch with mirror image branching, this one's the one that's strongly associated with congenital heart disease. So the only things you need to know, tell them apart, and that right arch with mirror image branching is the bad one. That's the one that has an association with tetralogy of Fallot and truncus. Remember I said those are the two right arch ones that you need to remember. Now here's the trickery that occurs. So big trick question here. Most common versus most closely. Well, what the hell does that mean? Basically it means that tetralogy of Fallot is much more common than truncus. So if you have a mirror image right arch, just see a picture of a mirror image right arch, then 90% of the time you are going to be dealing with tetralogy of Fallot. Only 6% of the time you're going to be dealing with truncus. If the person has truncus, they are more likely to have a right arch, like 30% of the time, as opposed to tetralogy, which is 25% of the time. Okay, so here we go. Another question here. We're going to work through this. So they are telling us the patient is cyanotic, so we can go right ahead and eliminate the things that are not cyanotic, right? Not cyanotic. And then we notice that there's a right arch, but that doesn't help us so much because both TOF and truncus can both have right arches. Now, if you're asked to choose with no other information, you would pick tetralogy of Fallot because it's more common. So if you see a right arch, it's more common, even though truncus is more closely associated with it. The way you can tell the difference is because truncus has increased pulmonary vasculature, usually, and tetralogy of Fallot does not. So we're over on this part of the graph here. So how the hell do you tell the difference between pulmonary vasculature being too much, normal, or not enough? Especially not enough. That was always really hard for me. Like, how do I tell if there's not enough? I will simplify it and tell you that you don't have to tell. So too much is obvious, right? Looks like pulmonary edema. Just clumped together, decreased, and normal. Just, if it's not pulmonary edema, it's either pulmonary edema or it's not pulmonary edema. It's just much easier to do it that way. So those are your things that have increased pulmonary vasculature, okay? And then those are your things that have decreased or normal. So things that are affecting the right side of the heart, Epstein's, tricuspid, decreased. It's not, blood's not able to get out into the lungs. And TOF also, which has pulmonic stenosis is a big component of that, right? So we can see that it's not increased, right? It's not increased. So that's your TOF case. All right, so the next thing is whether or not the heart it's either really big, massively big, or it's not. So a really massive heart, we'll go back to that. So is there a massive heart or not? Now, we said, hey, that's Epstein's, right, when it's a really massive heart, or it's pulmonary atresia without a VSD or an intact pulmonary septum, or interventricular septum. But there's another thing. You can have trick cases that will show you a really big heart, but the heart is structurally normal. Well, how can that be? High flow states, and there's two of them that you need to know. One is the vein of Galen malformation, which is an intracranial shunt where you have 80% of your cardiac output being shunted through this fistula in the head. Sometimes they'll tell you that there's been a bruit on cranial ultrasound. Other times they can just show you a big ball, vascular ball in the middle of the head, or a big enhancing ball in the middle of the head. And it's not actually malformation of the vein of Galen. And I talk about this in the congenital peds neuro talk. But it's basically persistence of a precursor that you've got that there. I don't think they'll get into that. It's much more likely they'll either show you the heart or show you a picture of the head or tell you a cranial bruit buzzword. The other one to know is this, which is a liver tumor seen in a kid that basically newborn, less than 1 year old. And this is a hepatic hemangioendothelioma. Thing to know about this, they will involute progressively over time. They tend to calcify, and they have elevated endothelial growth factor. In other words, AFP, which you normally think about with liver tumors, that's not elevated. Instead, endothelial growth factor is. All right, so let's do another one here. Cyanotic heart. We've got a chest x-ray here. So we know it's cyanotic, and they've told us this, so we're thinking about the 3 T's. Can't not for sure what side the arch is on based on that picture. Heart size looked a little bit big, but not massive. So let's go back here. So now we have to determine whether or not the pulmonary vasculature is increased or not. So can eliminate those. And what do you think? Pulmonary vasculature looks increased, right? It looks increased to me. And remember I said things that are affecting the right side of the heart, tricuspid atresia, Epstein's, TOF, those types of things tend to have normal or decreased pulmonary vasculature. So eliminating that one, and then that's the one that we've got left over. Okay, so that's how you do that. Now, associations, these are the trivia questions, and this probably will be the majority of the congenital heart cases that you see. So let's just jump right into one here. So patient has congenital heart disease. Notice that they did not say cyanotic. They just said straight up congenital heart disease. They're not giving you any other information. Maybe they're showing you a picture of a chest X, or maybe they're showing you a picture of a foot. Doesn't matter. Answer is VSD. Well, why? Why is it VSD? VSDs are the most common congenital heart thing, unless they list bicuspid aortic valve, which is actually more common, but not symptomatic. So like in cadaver cases, bicuspid aortic valve is more common. If that was listed as a choice, you pretty much have to pick it. But it's not typically thought of as something that's like a childhood congenital heart. The problem with a bicuspid aortic valve is that it calcifies and stenoses earlier, and then you end up with bad aortic stenosis earlier in life. That's more severe. So it's something that presents later on. You wouldn't know somebody had a bicuspid aortic valve when they were a newborn unless you went trying to figure out whether that was, unless you CT'd their heart. You wouldn't know otherwise. So in a ped setting, think VSD. If it's like an adult question for congenital stuff, yes, technically a bicuspid aortic valve is more common. So there's a bunch of there are different types of VSDs. The membranous one is the one I remember is the most common. Chest x-ray stuff is non-specific. You can end up with a big left atrium, in which case you would see the big left atrial stuff like splaying of the carina, etc. Most of these are going to close spontaneously. So if I say patent ductus, what do you say? There are 3 classic things that you want to remember with this. The first one is prematurity, because remember that this closes at a certain time. The second thing is maternal rubella will keep that open. And the last thing is cyanotic heart disease. And you say, hey, wait a minute. I thought you said that PDAs weren't cyanotic. They're not cyanotic when they're in isolation, but remember all those cyanotic things required a way to mix the blood from the right side and the left side. So they either have big ASDs or they have this, PDAs. So people with cyanotic heart disease often require them. So in isolation, they wouldn't be cyanotic. they occur with cyanotic heart disease. So what do you see on a chest x-ray? Again, very nonspecific. Sometimes you can see this thing people will call a ductus bump. There's like an outward contour out the ductus. If you need to, you can keep it open with medications. Prostaglandins are used to keep it open. Or you can close it with medications also, like NSAIDs, indomethacin, is used to nail those prostaglandins and keep them, cause it to close then. And the way that I used to remember that was, it's actually prostaglandin E. I used to think about an E as like holding it open, and then indomethacin takes that away. You can close it with an Amplatzer device that's deployed from the venous side, not the arterial side. And if it's really large and doesn't respond to medications. So let's talk about the different ASD types. So here's a heart, and let's say we'll cut a hole in the heart to have a look inside. There's a tricuspid valve. So if you have an ASD that's near the vein or near the SVC, I'll call that a sinus venosus, V for vein. A little bit further down is your ostium secundum. That's the second one down, but it's the most common right there. And then the third one to remember is this ostium primum. And even though it sounds like it would be in charge like Optimus Prime, it is actually number 2 overall. Secundum is more common, primum is bigger. So here's the things to remember. 4 major types. Here's the trivia to know. Secundums are the most common. They will the ones that will close without treatment most of the time. The larger ones will not. Primum is the big one. It's an endocardial cushion defect. It's associated with Downs. If you don't know the answer and I ask you what's this associated with, Downs is often the answer, just like GI stuff in peds. AV canals, also an endocardial cushion defect, also associated with Downs. Sinus venosus, ASD, the thing to remember with that is it's near the SVC, hence the venosus, and it is associated with partial anomalous pulmonary venous return. So let's review. When I say ostium primum or endocardial cushion defect, you say Downs. When I say ASD that closes spontaneously, you say spontaneously S for S for secundum. And of course, the common one would be the one that would close spontaneously. Not everybody's getting their ASDs repaired. When I say hand and thumb defects, like missing a thumb, you say Holt Oram. That's associated with ASDs. And then lastly, this thing right here, this is a classic picture. When I say sinus venosus ASD, you say right-sided partial anomalous pulmonary venous return. So basically, you've got 4 pulmonary veins, right? Now, if it's all 4 of them, that's total, and that's different. That's a cyanotic thing. This is a non-cyanotic thing. And this means there's just one of them. And if it's the right-sided one, that's the one that's associated with the sinus venosus ASD. And that's the most important piece of trivia to remember. Remember, total is all of them, okay? And requires a large patent foramen ovale. And there are 3 types, only 2 of which are going to be you only need to know about for testing. We mentioned the supracardiac one, the one that looks like a snowman, but there's another type that you need to know as well, and that is the infracardiac type. The type 2 or the cardiac one, the one that's in the middle, I would just don't worry about that one. So here is type 3, and the situation here is that instead of draining up above into the SVC, it's draining down below. So something like this. So I've got blood here, it's draining, but notice that it sort of gets hung up at the diaphragm. And as we continue to pump blood, we continue to get hung up at the diaphragm, and it's, like a traffic jam occurs there. And because of this traffic jam, you end up backing blood up, and you get pulmonary edema. So the thing to know about this is obstruction, which occurs basically on the way back through the diaphragm, is common and causes a full-on pulmonary edema pattern. So that's your type 2, or type 3. Your type 1 is your supracardiac, that's your snowman. Type 2 is cardiac, don't worry about remembering that one. And type 3 is infracardiac, and that's the one that has the pulmonary edema one. So key things to remember: supracardiac snowman, infracardiac pulmonary edema in a newborn. You have to have a large ASD or patent foramen ovale to survive. And asplenia, the heterotaxia, is, remember from the GI or pediatric talked about asplenia being associated with congenital heart disease. Well, this is the one that it's most commonly associated with. So, transposition, this is, we mentioned this earlier, the O looks like an egg on a string, transposition. And what it actually is you've got the aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle. So they're transposed. And there are two different types. There is a bad one, which is type D, and the way that I remember that is D is for doomed. And there is a good one that is an L type, and the way I remember that is L is for lucky. So this is the D type. This is what we've got going on here. We've got systemic blood that's returning to the heart. It's not oxygenated, and it's being pumped through right atrium to the right ventricle. And then the aorta, which doesn't belong there, right? Aorta normally comes off the left ventricle. In this case, it's transposed onto the right ventricle, has no oxygen, so still no oxygen, and that's getting pumped back into the body, so you're circulating unoxygenated blood. That's bad. You can see why this would be one of the cyanotic heart diseases. Then it starts with a T. And then on the left side, you do have oxygenated blood that's returning from the lungs, and it's being pumped out into the pulmonary artery, back into the lungs again. So it's like in a loop that's isolated from the systemic circulation, so that oxygenated blood is not getting to the body. So you're like, well, how are you not dead? You require either a big ASD or a PDA, some way to get the blood across there. And this is the bad one, the D type, that's for doomed. Now, here's the good one, which is sometimes referred to as a double discordant, where not only is the aorta hooking up on the wrong side, but the right atrium is actually attached to the left ventricle, and the left atrium is attached to the right ventricle. So there is a switching that is occurring not only at this level, but also at that level. Okay, so we've got blood coming in on the systemic side into the right atrium that's not oxygenated, and then it's moving from the right atrium to the discordant left ventricle that shouldn't belong there, and then it's going to exit through the pulmonary artery, which should hook up with the right ventricle, but since the right ventricle's on the other side, so this is this double discordant, and then it's returning to the left side of the heart through the pulmonary veins, now with some oxygen, and it's moving out through the aorta. So you can see why this would be lucky, where you are actually taking oxygenating blood and connecting it from one side of the heart to the other, and it's occurring because of this double discordant effect, where not only are the PA and the aorta hooked on wrong, but the ventricles are hooked to the wrong atriums. So some people, the way they can ask this is they can use tricky wordage and say it has to do with a relationship with the mitral valve and the left ventricle, or tricuspid valve and the right ventricle, and that kind of stuff. But what they're getting at is this relationship here is what's making this. That's where the discordance is occurring. So if there's a single discordance that's occurring here, that's the doomed type, and if there's a second discordance that's occurring here, then that's the lucky type. Okay, so here we go. This is sort of like the question that we asked earlier, which is like, what, without any other information, this patient has cyanotic heart disease. What does he have? And you know from our prior exercises that it's not one of these two, but these are both cyanotic, but TOF is much more common. So, as mentioned before, tetralogy has 4 parts. We use the mnemonic PROVE to remember that. It has a strong association with the right arch, and I mentioned that the worse the pulmonic stenosis is, the worse the patient does. So here's how I remember this, and this is how I think about it. Think about tetralogy of flow as a malalignment VSD. So what do I mean by that? This would be a normal situation here developmentally, where you've got your right ventricular and left ventricular outlet tracts. And if you've got malalignment here, see that? So like that, if that happens, then suddenly you've got pulmonic stenosis, you've got right ventricular outlet stenosis. Your aorta is now overriding. You've got a big honkin' VSD, and because you've got pulmonic stenosis, you develop right ventricular hypertrophy, and remember that's what causes that upward tilting apex, and that occurs late. That's not present at birth. So there you go. So it's all because of that malalignment that occurs at the top of the septum there. All right, so moving on. Patient has cyanotic heart disease and DeGeorge syndrome. What does he have? So this is an association question. I've told you this, so we know we can eliminate here and here. We're stuck with 2 forms of cyanotic heart disease, one of which has a strong association with this chromosome 22, and that would be truncus. So this is a thing that you need to remember. 2 things I would remember about truncus. One is that it has a right arch. I remember it's more closely associated with the right arch, but it's more, or it's less common than tetralogy. And the second one is this catch-22 genetics, which, if you remember from step 1, is a DeGeorge syndrome thing. Now, so what is truncus? It's basically a common trunk where you've got a combined pulmonary artery and aorta. Like at the beginning, they, instead of having separate origins, they have one origin and then they split. So what is the most common association with a coarctation of the aorta? This is another association question. You just have to know this. And that's the presence of a bicuspid aortic valve. So what do you need to know about coarctations? Turner syndrome and bicuspid aortic valves. And they also have more baryaneurysms. The figure 3 sign that we talked about on the chest x-ray, those are the big things I would know. The other thing that I would know is that there are 2 basic flavors. The infantile or the preductal form, which presents with pulmonary edema, and the adult form or the postductal form, which presents with different blood pressures and, between extremities. So the adult form tends to be more long segment. Like I said, it will present later. The adult form, or the infantile form, is the preductal form, like premature, preemie, think about infants. Post, later in life, post, think about adults. Short segment on the preductal form, pulmonary edema. Presents early, right? Presents early. Something that would make you present early, you can remember that, is the infantile type. Something that would make you present as an adult would be the adult type. Okay, now let's talk about left-sided hypoplasts. What do they have a strong association with? They have a strong association with aortic coarctation. It's often seen with a left hypoplast heart. So these guys are screwed. This is a really bad situation. They really can't do much about it, although they certainly try. And we'll talk about that some in the next lecture. Essentially, you've got a left ventricle that doesn't develop. Remember, the left ventricle is normally the big, strong ventricle, and it doesn't develop normally at all. So it's really, really weak. And then they've got these coarctations, and they also tend to get endocardial fibroelastosis. Now, the only way they can survive is with a large AST or a PFO, and we'll talk about these some more in the next lecture. Here's another entity. This is an ant mini appearance. This right here sort of looks like there are 3 atriums. That's why it's triatriatum. Is part of the name. And sinisterium basically means that it's on the left. People that were left-handed were thought to be sinister back in the Stone Ages because that was a violation from the, was it, I don't know, 90% of people are right-handed, something like that. And so you're in a minority, so you must be evil, and hence the name. So the classic history for this is pulmonary hypertension, unexplained in a pediatric setting. Essentially what happens is you have this abnormal pulmonary vein that's draining into the left atrium, and because of this, you end up getting an unnecessary flap or membrane there, which results in a physiology similar to mitral stenosis, which can cause pulmonary hypertension. They don't do well. So, a couple of other things. Aortic stenosis, talk about that. Remember, I mentioned that bicuspid aortic valves are very common. They tend to occur, it's congenital. It looks like a fish mouth instead of a Mercedes-Benz sign, which is the normal look to an aortic valve. They're going to present later in life with aortic stenosis, so like faint syncope and stuff like that. So, they also will end up getting dilation of the ascending aortic root because you get jet through this stenotic aortic valve, and that blasting jet can lead to dilation there. If they would ask you, you can grade how bad this jet is, which is then useful for saying how bad the stenosis is through this velocity encoding, MR or VENC. That would make a good next step question for cardiac MR, which we will have a talk on. There are 3 different kinds, and it has to do with where in relationship to the valve the stenosis occurs. Stenosis at the valve is the most common, but you can also have subvalvular and supravalvular. Supravalvular is one that's worth remembering because it has a syndromic association. So when I say supravalvular aortic stenosis, you say Williams syndrome. This is the elven-faced, cocktail personality, dwarf. Bicuspid aortic valves and coarctation, you're going to say Turner syndrome. Remember, coarctation, Turner syndrome, coarctation plus bicuspid aortic valve, they go together. So what about aortic regurg? So aortic regurg is common, and you could have a whole bunch of different causes. A bicuspid aortic valve can also cause regurg, but you think about it more classically with stenosis. Marfan syndrome, bacterial endocarditis, anything that's like destroying that valve. Now, how rapid the regurgitation occurs, it tends to be how bad the patient does. In other words, if we don't have time to compensate. And we talked about this in the chest lecture. We can have a double density sign here, widening of the carina here, and then posterior displacement. So this tends to be something that you see with mitral stenosis. So mitral stenosis occurs, and then your left atrium has to try to pump harder to get past that stenosis, and it enlarges. When I say mitral stenosis, you say rheumatic heart disease. Rheumatic heart disease is the most common cause of mitral stenosis. A case that shows left atrial enlargement is a classic way to make you infer that this patient has mitral stenosis. Now, if you may remember that mitral regurgitation is classically associated with isolated right upper lobe edema. And there's a complex reason for that, is irrelevant. But when I say isolated right upper lobe pulmonary edema, you need to think mitral regurgitation. Basically, you end up having a jet that's directed just to the right upper lobe. Again, these do worse in a rapid onset situation, just like aortic regurg. And so if you have, and step one question was that you have an MI that takes out a papillary muscle, and then you develop this thing called an Austin-Flint murmur. Whether or not that's a real thing, I don't know. But remember that for boards questions, the people who write these things like to pretend that radiologists are, quote, real doctors. So anything that sounds like family medicine, physical exam, laboratory values, medication side effects, all this kind of stuff that you think, I don't have anything to do with that. Don't be surprised if somebody does think it's important. So Austin-Flint murmur with the papillary muscle gone down, causing mitral regurg. Chronic, this is more of myxomatous degeneration, mitral annular dilation. These are the people that you see that have mitral annuloplasties that you see all the time. That's more of a degenerative kind of thing that's going down. And again, the right upper lobe pulmonary edema. So just like aortic valve, there's three, you can have different syndromes associated with where the stenosis occurs. Now, and just like with the aortic valve, supravalvular stenosis is also seen with Williams syndrome. If you had to pick, aortic valve is more common for the supravalvular aortic stenosis with Williams, but it can occur with pulmonic stenosis as well. Valvular is this thing called Noonan's syndrome, which is like the male version of Turner syndrome. And subvalvular is your tetralogy of Fallot. That's your outlet obstruction from the, remember, it's a malalignment VSD, like the animation that I showed. There's also an entity called Alagille syndrome, which is causes a peripheral pulmonary stenosis. And the thing to know about that is buzzword peripheral pulmonary stenosis and absence of the intrahepatic bile ducts. That's bad. It's a bad situation. So, all right. So when tetralogy of Fallot goes bad, why does it often go bad? And we'll talk about this a little bit in the next lecture. But part of what they do when they repair it, because remember how bad your disease is has to do with how bad your pulmonary outflow obstruction is, or your right-sided outflow obstruction is. So they will try to correct that. But what you can end up having is pulmonary valve regurgitation. So this is a common postoperative sequela. It leads to progressive right ventricular enlargement and dysfunction, and it's a important determining factor. And they will often actually monitor them for this. Like, is their RV getting bigger? Is their RV getting bigger? And when it meets a certain threshold, then they have to go in there and repair it, or they can end up with arrhythmias and sudden death. So the classic scenario for pulmonary regurgitation is actually in a patient who's had a TOF repaired maybe 10 years before that, 15 years before that. So what about tricuspid regurg in adults? Why does that happen? Well, this happens because of pulmonary hypertension. And the general idea is you get pulmonary arterial hypertension, the RV dilates, and that stretches the tricuspid annulus, and then you end up with regurg. The tricuspid annulus is not as strong as the mitral annulus. It can't tolerate a lot of, any right ventricular hypertrophy is going to cause that tricuspid annulus to become, it just doesn't tolerate it well. It doesn't take much to tear it, or stretch it anyway. So, having said that, an uncommon but highly testable cause of tricuspid regurgitation is actually carcinoid syndrome. And this, it's just like step one. People write step one questions, love this because of the physiology involved. Obviously, endocarditis can always tear up your valves, and pulmonary hypertension, as we talked about too. So here's the deal with carcinoid syndrome. You get a carcinoid tumor, which is most commonly in the appendix or small bowel. That's your primary. Usually can't find the primary. Usually what you see on CT is this metastatic deposit in the mesentery that's causing a desmoplastic reaction. And then eventually, if it's untreated, will metastasize to the liver. Notice their arterial enhancement. It tends to be a hypervascular tumor. And once a certain percentage of the liver is taken down, it's a large percentage. Let's say it's 50-60% of the liver is involved with tumor. You overwhelm your ability to metabolize the serotonin. Because prior to that point, any serotonin that's being made from this carcinoid tumor in the mesentery or in the appendix gets metabolized through the portal blood system, and you never end up with systemic flushing and all those kinds of things that they talk about with carcinoid syndrome. But once it overwhelms the liver, then it's unable to metabolize the serotonin, and then you end up with serotonin, extra serotonin in the blood. And this actually is toxic to heart valves. Well, which heart valves? Well, because it's entering the heart through the vena, it's going through the portal venous system and then draining into the IVC, and then the IVC drains into the right heart. You get a situation like this, where it's bouncing around in that right heart system. So your tricuspid valve and your pulmonic valve are the ones that are going to get degraded, and they both can end up with regurgitation. So serotonin syndrome affects the tricuspid valve and the pulmonic valve, and that's how you can remember that. Now, there's some trickery that can ensue where you have degradation of the aortic and mitral valve. Well, how can that occur with carcinoid? Well, there's two possibilities. One, you've got an endobronchial tumor. The lungs actually metabolize serotonin just like the liver does, and that's why you don't have it normally affecting the left side of the heart. But if you have an endobronchial tumor, it's going to circumvent the lungs, and you're already past the liver, so then it would affect your mitral and your aortic valve. The other scenario is that you have a shunt, anything that can circumvent the lungs. So, accentuated levocardia, this is a buzzword for this finding. Notice that the heart is displaced to the left, and it's like right up against the chest wall. So this is one of these like two-part thinking questions where you have to know what that picture is. And that picture is absence of the pericardium. Now, typically, you can't have complete absence of the pericardium, but it's usually just partial left-sided absence. And what ends up happening is the heart gets displaced, accentuated to the left. And because it's only partial pericardial absence, there's like a hole, and through that hole, the left atrial appendage can protrude and become strangulated. So this is an Ant-Mini. Congenital or acquired absence of the pericardium causes displacement of the heart to the left, and just remember that the left atrial appendage can be strangulated. Just a few more things here. Remember I said differentials don't make good multiple choice test questions, but it's useful to know a few of them for clues to help you eliminate other distractors if this information ended up in the subject header or if they just had really bad distractors. So the first one is CHF in a newborn. These are some things that we talked about. Total anomalous pulmonary venous return, the infracardiac one, remember the one that it's getting built up through the diaphragm and ends up backed up into the lungs. Really bad aortic or mitral stenosis, so blood being backed up because it can't make its way through the left side of the heart. Left-sided hypoplasts, core triatriatum, because remember that acts basically like a mitral stenosis. Sinisterium anyway, the left-sided one. And then infantile or preductal coarctation. Remember I said that one is the one that presents early. And how it presents with is pulmonary edema, because you are, again, you're causing a traffic jam on the left side of the heart. Small heart, one that perhaps is 3 sizes too small. There are some things that do that. The classic one, if you can remember any of them, is Addison's disease or adrenal insufficiency. Other things that you see more in adults are someone who's cachectic or someone who has constrictive pericarditis. And then lastly, this is something I've mentioned repeatedly throughout the talk, is who has to have a PDA, VSD, or ASD, and these are the people who are cyanotic that need to be able to mix their oxygenated blood with their unoxygenated blood because their physiology isn't allowing them to do that normally. Okay, that's the end of the first talk on cardiac, and we'll follow up with some more points specifically concerning surgical correction of some of these things in the next talk.